Hello and good afternoon to everyone. Welcome to another edition of OrthoCarolina's monthly webinar series. My name is Dr. Petros Koutsogiannis, and I'll be talking about degenerative spondylolisthesis, or put more simply, arthritis in the low back, which leads to instability. This is being live streamed on our Facebook, LinkedIn, and YouTube platforms, and please do not hesitate to ask any questions, and I'll try to address them all. Next slide. So a little bit about myself. I'm a South Carolina native, obtained my bachelor's in biology, and I minored in chemistry from the University of South Carolina. I then went on to complete medical school at PCOM outside of Atlanta, Georgia. I then spent 5 years in New York, where I completed my orthopedic surgery residency training at Hofstra University Northwell Health System. I also completed a 1-year subspecialty training in spine surgery at the William Beaumont University Hospital in Royal Oak, Michigan. It is a U.S. News and World Report top hospital for orthopedics and for spine surgery. I am now a spine surgeon at OrthoCarolina, and I look forward to providing exceptional care to the community where I practice. Next slide, please. So in order to fully understand the pathology or what goes wrong behind degenerative spondylolisthesis, we must first understand some basic anatomy. For this talk, we'll focus on the lower spine or the lumbar spine. In this region, there are 5 vertebrae of individual bones that provide support and structure to our spine, as well as 5 discs, which act as shock absorbers in between these bones. Looking more towards the back portion of the spine, we find the facet joints as labeled. This region is where most of motion occurs. Motion such as bending forward and bending backwards and twisting. These 3 components are important to our overall function, and when they break down, it can cause pathology, as we will get into it a little bit later on. Now, as we look in between these 2 areas, in front of the facet joints and just behind the vertebrae and the discs, we'll find something called the nerve roots. Here, there are 5 paired lumbar nerves and 5 paired sacral nerves. These nerves provide sensation, movement to our lower extremities, and also our bowel and bladder function. If affected, they can also create nerve pain in our overall function of our lower extremities. Next slide, please. Now, having that basic knowledge for the anatomy, we'll focus on the pathology, or what goes wrong to cause a degenerative spondylolisthesis. Arthritis is not fully understood. However, we know there's a genetic component, aging, wear and tear that leads to cartilage breakdown. Once this cartilage erodes away, the bones begin to rub on bones, and this eventually creates inflammation, pain to the area, and leads to a loose joint. As we mentioned earlier, when that joint, the facet joint, becomes loose, this can cause slippage of one vertebrae, or that bone, as we mentioned earlier, as depicted in this picture, on top of another vertebrae. This is more involved, including some thickening of some ligaments, some disc herniations. However, knowing this basic concept will help you better understand the symptoms and the treatments involved for this condition. This loose joint can cause back pain, can narrow the foramen or the tunnel from which the nerve exits out, and can cause nerve pain, and in severe cases can cause weakness and even sensation loss. Next slide, please. So us doctors commonly describe spondylolisthesis as either low grade or high grade, depending upon the amount of slippage. A high grade slip occurs when more than 50% of the width of the vertebrae slips forward on the one below. Patients with a high-grade slip are more likely to experience significant pain, nerve injury, and the need for operative surgery intervention to relieve these symptoms and prevent further deterioration. This is a simple picture just showing the classification. I believe it's important just to have a basic knowledge that there are high grade and low grades. Therefore, if and when you speak to a physician such as myself, you'll be able to understand what they mean when they say this is a high grade slip or a low grade slip. Next slide, please. In many cases, patients with spondylolisthesis do not have any obvious symptoms. These conditions may not even be discovered until an X-ray is taken for an unrelated injury or condition. When symptoms do occur, the most common symptom is lower back pain. The pain may feel similar to a muscle strain, radiate to the buttocks, the back of the thighs. It may worsen with activity and improve with rest. In patients with spondylolisthesis, muscle spasms may lead to additional signs and symptoms, including back stiffness, tight hamstrings, the muscles in the back of the thigh, difficulty standing and walking. Spondylolisthesis patients who have severe or high-grade slips, as mentioned earlier, may have tingling, numbness, or even weakness in one or both legs. These symptoms result from pressure on the spinal nerve root as it exits out of the spinal canal near that slip. Some more advanced cases can cause something as a foot drop, as depicted in this image. This is where an individual is unable to lift their ankle, and as you can imagine, this can interfere with walking. Next slide. Your doctor will begin a medical history and ask about your general health and symptoms. They will want to know if you participate in any active activities as well. Your doctor will carefully examine your back and spine, looking for areas of tenderness, limited range of motion, muscle spasms, weakness. The doctor will also observe your posture and your gait, the way that you walk. In some cases, having tight hamstrings may cause a patient to stand awkwardly or walk with a stiff-legged gait. Imaging tests will help confirm the diagnosis of spondylolisthesis. We usually start with an X-ray and will perform images while bending forward and at times bending backwards as well to measure a change of the slippage. This will confirm that the slip is unstable. An MRI may also be ordered to further look at which nerves are pinched and the extent and severity of that. Sometimes we may order a nerve study which looks at the pinched nerves, and it helps put the whole picture together. Usually it's reserved for patients or individuals where the picture may not be as clear. They may also have nerve damage from other conditions such as diabetes or peripheral neuropathy from vascular disease. Next slide, please. So why is it important to understand all of this? Well, the usual level affected for degenerative spondylolisthesis or arthritis in the low back creating instability is L4-5. Therefore, having this low back pain that's worse with activity, having the leg pain, either one side or both sides, will usually match a pretty predictable pattern, especially when your doctor orders an X-ray and an MRI and puts the whole picture together. This is because the foramen, as I mentioned earlier, or the tunnel where the nerves exit out, becomes smaller, and the nerve traveling through this area can get pulled and pinched. This will cause buttock pain, leg pain, traveling down to the foot. Goals for treatment, therefore, focus on alleviating the low back pain and the pinched nerves from this slipped area. Next slide, please. So getting into the treatment, for most patients, especially those with low-grade spondylolisthesis, back pain and other symptoms will tend to improve with non-surgical treatment. Non-surgery includes rest, avoiding activities that place excessive stress on the low back for a period of time. That can often help the low back pain and other symptoms. Non-steroidal anti-inflammatory medications such as NSAIDs, ibuprofen, Aleve, diclofenac, to name a few. These help reduce swelling and relieve back pain. Physical therapy, specific exercises can help improve flexibility, stretch out those tight hamstrings, and also strengthen the muscles of your back and abdomen, which helps support the area of pain. Next slide, please. Surgery may be recommended for spondylolisthesis in patients who have severe or high-grade slippage that is progressively worsening, back pain that has not improved after a period of non-surgical management, usually at least 6 weeks and sometimes up to 7 months. So surgery is not only recommended for patients with a high-grade slip, it can be recommended for a patient with a low-grade slip who does not get better with conservative treatments as posted in our previous slide. Spinal fusions happen between a vertebrae above and below where the slip is. It's a surgical procedure most often used to treat this condition. The goals of spinal fusion are to prevent further progression of the slip, stabilize the spine, alleviate significant back and leg pain. Usually this procedure is more effective at alleviating the leg pain. It can help to improve some of the weakness and bring back some of the sensation that might be lost before the surgery as well. Spinal fusion, again, it's essentially a welding process. The basic idea is to fuse together the affected vertebrae so that they heal into a single solid bone. Fusion eliminates motion between the damaged vertebrae and takes away some spinal flexibility. However, the theory behind it is that if the painful spine and nerves segments from it do not move, it should not hurt as well. Next slide. So I have this slide here as a quick overview for the different types and ways to achieve a fusion procedure. Recent studies suggest no one technique is superior to the other. It should be patient-specific and based on the surgeon's experience and comfort level with a specific technique. Essentially, all can accomplish the same goal, and those include: first, realign the vertebrae in the lumbar spine. Small pieces of bone called cadaver or allograft, meaning your own bone, are then placed into the spaces between the vertebrae to be fused. Over time, the bones grow together, similar to how a broken bone heals. Prior to placing the bone graft, your doctor may use metal screws and rods as depicted in the image in the back and from the side, a front, or all in the back procedure. In some cases, patients with a high-grade slip will also have compression of the spinal nerves. In this case, your doctor may perform a procedure to open up the spinal canal and relieve pressure off of these nerves before performing the spinal fusion. This can also be done with either technique shown above. Once again, these techniques can be done from the front, from the side, or all from the back, depending on the levels, patient-specific, and the physician or doctor's preference. Next slide. So as far as the do's and the don'ts in your recovery period, majority of patients with spondylolisthesis are free from pain and other symptoms, sometimes within a few weeks or several months after a spinal fusion procedure. In most cases, the patient can gradually resume sports and other activities with a few complications or recurrences that could happen. To help prevent future injury, the doctor may recommend that you do specific exercises to stretch and strengthen the back and abdominal muscles. In addition, you'll need regular checkups to ensure that problems do not develop during your recovery period. The goal here is to reduce your symptoms that were present before, establish a fusion, and doing everything that you enjoy doing on a daily basis. Next slide. So that concludes this portion of the OrthoCarolina live webinar series. Now is the time that we will open up the floor for any questions. So it seems as if the first question we have here is back pain hereditary? This is a question that I get asked pretty commonly in my practice, and back pain is multifactorial, meaning there is a genetic component, as I presented in my slide, that the genetic component can lead to accelerated arthritis, accelerated degenerative disc disease, the shock absorbers between the bones. That can be a precursor to causing more symptoms and more pain. So there is a hereditary component. However, it's multifactorial, meaning there's also age involved to it, also activity level. Certain individuals who are more active than others, that had more contact sports experiences in the past, etc., are at an increased risk for obtaining these conditions. So yes, it is, and it can be hereditary. However, it's not just that one factor. So another question we have here is, how effective and safe is an epidural at C6 to 7? And what are the risks of spinal injections? So that's a very good question. My topic was focusing on degenerative spondylolisthesis of the low back or the lumbar spine. Generally speaking, epidural injections are part of that conservative treatment protocol, as I mentioned in my slide, before someone may require operative or surgery intervention. The cervical spine, C6 to 7, is further up from the lumbar spine where I was talking about. And generally speaking, injections are relatively safe and have a low risk profile. However, anytime you are in the cervical spine, so higher up, those risks are slightly increased. And from my understanding, not every individual does epidural injections at a cervical spine level. Certain physicians do. And if that is something that you're pursuing, I would talk with your spine surgeon to find the appropriate individual who's comfortable performing that epidural injection for you. For the most part, they're relatively safe and can provide significant relief and can be a precursor to including a post-op, conservative treatment option before you needing surgery. So they're relatively safe, and I would have that conversation with your spine surgeon or other orthopedic surgeon to find the right individual to perform that procedure for you. Another question we have here is, when I get up from sleeping, my legs hurt so badly that I can't walk correctly. What could be the cause of this? So this is a very good question, and a lot of my patients have similar symptoms. Legs hurting badly and not walking correctly could be a cause of spinal stenosis or spondylolisthesis. Usually, patients with this condition that I just presented have something called get up and go pain when they're sitting down in a chair or laying down flat for quite some time, and they stand to start walking, they experience a lot of pain and leg heaviness and legs feeling wobbly. That's called neurogenic claudication, meaning they kind of feel like noodles. There's other conditions that could cause this. However, one of them could be a spondylolisthesis. I recommend that if it is significantly interfering with your quality of life, your sleep, your daily living activities, make an appointment with your primary care physician to refer you to an orthopedic surgeon, orthopedic spine surgeon, or a neurosurgeon to further evaluate your condition. It could be coming from your lumbar spine, as I presented in this topic of talk. So the next question we have here is, do the treatments for spondylolisthesis and degenerative disc disease vary by age? Very good question. For the most part, treatments are the same across all age groups. Usually, what may alter the way we perform a certain procedure, if a patient is failing conservative treatment, may alter depending on the activity of the individual and also the bone quality. And that can correlate with the age of an individual. As far as conservative treatments goes, physical therapy, anti-inflammatory medications, considering an epidural injection, those do not vary between age groups. Surgery usually for a spondylolisthesis, meaning there is clear instability, requires a fusion procedure. Fusion procedure does not vary dependent on age either. The goals are the same. The goals are to create a good fusion between the two vertebrae or the bones that are slipping. How to achieve it might vary slightly depending on age or bone quality. And that's a conversation that usually a spine surgeon will have with you in detail. If you're needing a fusion procedure, ways to achieve it with poor bone quality or good bone quality could vary. So that's a very good question. Okay, so another question we have here is, How can pain be managed while on blood thinners? And what are the best topical pain relievers? So that's another very good question. And as many may know, or some may not, blood thinners, the way some pain medications, as I described, non-steroidal anti-inflammatories, may interfere with most blood thinners. Therefore, we try to avoid using non-steroidal anti-inflammatory medications such as naproxen, meloxicam, ibuprofen, etc. Sometimes, because patients are blood thinners that can't come off of them, we can try some topical pain relievers. I would recommend that, depending on what blood thinner you're on, talk to your cardiologist and who prescribed those. Talk to your primary care physician as well. Sometimes, if there's a close eye on your laboratory work, there are certain non-steroidal anti-inflammatory medications that can be prescribed for a short period of time if you have an exacerbation. For long-term, maybe not. So that's number one. Number two, as far as topical goes, usually most of them are pretty safe. And now some of them are over the counter. However, I would recommend you speak with your primary care physician or your orthopedic surgeon to provide you a prescription grade as well. And from my experience, diclofenac works pretty well for certain conditions. A lot of times they may not work for low back or cervical because there's a lot of soft tissues between the deep joints in the back and your skin. However, around joints such as the elbow or the wrist or the knee, they can be very valuable. And I would recommend you talking with your primary care physician and your spine surgeon or orthopedic surgeon to see which ones are best for an individual who's on blood thinners. Next question we have here is, how can scoliosis and spinal stenosis be managed? And what exercises should be avoided? So this is another great question. Usually we want our patients to be very active. We want our patients to have good muscles in the low back, in the abdomen, because that helps keeps our spine upright and supported, okay? As far as scoliosis goes, that's twisting of the spine, okay? And stenosis can happen from the twisting of the spine. That's compression of the nerves. Usually, exercises that will help alleviate that include core, abdominal, and low back and upper back strengthening. Those are the muscles that keep us upright. What I tell my patients, there's plenty of exercises that can be read up online, but if you remember the P's, push-ups, pull-ups, and planks, those 3 P's usually provide enough support, if you build those muscles up, to alleviate some minor low back and upper back symptoms and at times leg pain. If you're consistently doing those exercises and you're still having pain and your symptoms are not being relieved or progressing, I recommend scheduling an appointment with an orthopedic surgeon or a spine surgeon or your primary care physician to provide you the right avenue where you need to go and be treated. But once again, to summarize, what I like to tell my patients are, remember the P's, push-ups, pull-ups, and planks. Those, for the most part, help strengthen all the core, abdominal, and back muscles that provide support for all spine conditions, including scoliosis with stenosis. Exercises to avoid, I would avoid anything that does not involve proper bending down, because that can damage the low back, damage the discs. Make sure you're bending with your legs and with your knees when you're squatting. Don't bend forward and lift anything heavy with your back. That, at times, I've seen can cause more injury instead of provide relief. So once again, I would avoid heavy bending, lifting, heavy twisting with scoliosis and spinal stenosis, and focus on push-ups, pull-ups, and planks. Another question we have here is, what is ankylosing spondylitis and how do you treat it? So ankylosing means fusing of bones, or usually our spine is a mobile segment. Our spine is made up of multiple small segments of discs, bones, and joints. That allows us to twist, that allows us to bend forward, move, and function. In this condition, it's not related to my topic. However, our body starts forming more bone where it shouldn't be, or in between the segments. So essentially, as I described, a procedure for spondylolisthesis, the condition I was talking about today, is a fusion procedure, meaning we put screws and rods over the segments that are unstable to eventually allow your body to lay bone down and create one big piece of bone where there is pathology. Essentially, in this condition, your own body is on overdrive, and for some reasons we know and some reasons we do not know, it's an autoimmune disorder. Your body lays down more bone in areas that it shouldn't. So then you become stiff and you can have a lot of pain. Usually, first-line treatment for this is exercises that I explained: push-ups, pull-ups, planks, physical therapy, anti-inflammatory medications. But at times, you need more medications that usually us orthopedic spine surgeons do not prescribe. And these are better suited talking about to your primary care physician and having established care with a rheumatologist. There are some medications that reduce your immune system being on overdrive, laying down more bone than it should at areas where it shouldn't, so that we can prevent this condition from progressing even more. I see this all the time, and I usually start with physical therapy, anti-inflammatory medications, and recommend follow up with a rheumatologist. Now, one other thing is, if this has been a condition that's been ongoing for quite some time and individuals have a very stiff back, they can have very bad breaks or fractures in their bones of the back. So if you do have this condition, try to avoid having falls, try to avoid having contact sport type injuries or hobbies that involve a contact, which will allow you to have a big impact in the spine, because that can create a big bad break. So I would avoid contact sports, horseback riding, things like that, and try to establish care with a rheumatologist. So we have another question here. Are back issues the source of hip pain? And this is a very good question. So it can be, depending on where the pathology is or where the destruction is in the joints, in the discs of the nerves in the spine. Okay. So what we do as spine surgeons is we play detective. We're also orthopedic surgeons, so we look at all the joints. And at times, hip pain is usually, if it's from osteoarthritis or degradation of the joint and cartilage, so bone rubs on bone, at the hip joint itself, it's more in the groin. So we always test our patients when we see them to see if they have groin pain. And at times, I like to especially take an x-ray of both hips while I include my low back x-ray to see if there's any arthritis. This is one way to differentiate: is it really hip pain from hip osteoarthritis, or is it referred hip pain from the nerves coming from the upper portion of the low back? So the upper portion of the lower lumbar spine, the nerves that come out of there through the tunnels, as I explained in my PowerPoint presentation, can provide some referred pain into the groin and upper thigh area, which may resemble hip osteoarthritis. So it can, usually it does not. However, it's our jobs as orthopedic surgeons and as orthopedic spine surgeons to help differentiate, is this a low back problem or is this a hip joint problem? And if you're uncertain but you're having hip pain, come see an orthopedic surgeon and we will try to find out exactly what the source of pain is. So another question here. What happens if treatment is not done for spondylolisthesis? So this is another very good question. Usually, when we diagnose spondylolisthesis, patients have back pain, and sometimes you'll have some leg pain, buttock pain, discomfort. If treatment is not done, then symptoms may progress over time or may stay the way they are. As I explained earlier in my slides, there are low-grade and high-grade slips. Usually, if slips are not progressing into the high-grade portion, the symptoms that someone may have could resolve on their own or could stay at that baseline. And if they're not debilitating, causing significant discomfort, interfering with someone's work, their daily living activities, their quality of life, then it's very reasonable to not seek further treatment with this condition. This condition, usually with some low back pain, at times leg pain, is not an emergency. Surgical treatment is not an emergency, and it is elective only when, as I explained in my slide previously, there's been failed conservative treatment for at least 6 weeks or sometimes even up to 6 months. So it's very reasonable to not seek any further treatment for this condition. However, if your symptoms are worsening, and we're getting into, as I explained in my talk recently, just previously, having a foot drop, having foot weakness that's interfering with your ambulation, significant discomfort, having a lot of sensation loss, leg heaviness, difficulty moving your legs, significant weakness where we can't walk anymore like we used to. That's a different topic of discussion where usually further treatment is more warranted. So another question we have here is, does spondylolisthesis cause you to sometimes lose your balance? That's a very good question, and it can. So usually the way that can occur is by something called neurogenic claudication, or pinching of a lot of the nerves that control your legs, and that can make your legs wobbly when you walk. It can also occur from having a lot of back pain. Usually when you try to start walking, because the spine is unstable at that joint, as explained earlier in my talk, it can cause pain, and your legs can also feel wobbly and cause you to lose your balance. Now, there's also other conditions that can cause this, and related to the spine and related to the upper portion and mid portion of the spine as well. Therefore, if you're having a lot of difficulty with your balance, I recommend you seek care by an orthopedic spine surgeon or a neurosurgeon, because sometimes there can be some severe pathology behind it that needs to be addressed. That concludes the webinar series for spondylolisthesis. Thank you so much for everyone attending, and have a great afternoon.